Good morning. Welcome to In the Trenches with DAC. This morning's topic is going to be ascites. It should be noted that in a prior presentation, I talked about pleural effusions, but ascites, peritoneal fluid, is approached a little differently. So when a patient presents with ascites, and assume it's a patient that has new onset ascites, you need to figure out what the etiology is. And what you use for this is a SAG, serum ascites albumin gradient. With pleural effusions, you have transidate and exudate. That's just for pleural effusions. That does not apply to ascites. Ascites you use a SAG, and you can divide that up into an increased SAG, which is greater than or equal to 1.1, and a decreased SAG, which is less than 1.1. So with an increased SAG, the number one thing you think of is cirrhosis of the liver. We'll talk about this in a minute. And anything that causes portal hypertension could do this. So besides cirrhosis of the liver, you could see this with portal vein thrombosis. You could also see it with hepatic vein thrombosis. And you could also see it, although we don't see it that commonly, with CHF, right-sided heart failure, or constrictive pericarditis, anything coming from the heart. With the low SAG, what you're thinking of here, unfortunately, malignancy, tuberculosis, connective tissue disease, although they don't usually cause ascites, they can, and pancreatitis. And then there's some unusual conditions like Meigs syndrome. Okay, cirrhosis of the liver is the most common cause of ascites. The mechanism is as follows. You have increasing intrasinusoidal pressure. And that occurs because of proliferation of stellate cells in the liver. And it causes fluid to leak out of the liver into the peritoneal cavity. And you couple that with abnormal startling forces because these patients are vasodilated and they have decreased effective arterial blood volume. And you have aldosterone stimulated. And these patients also have low albumins, and it causes fluid to pool in the abdomen. That's the mechanism. So the tests you order when you're doing a peritoneal tap, when you're doing a paracentesis, you're going to order an albumin, and you need a serum albumin to calculate the SAG. You're going to order a cell count with diff, and you're going to order micro. These are the big three things. It's not like pleural effusions where you're going to get a protein and LDH and calculate a ratio and use Light's criteria. That's just for pleural fluid. So if somebody has cirrhosis, you're going to have an increased serum ascites albumin gradient. Now, the cell count with diff is important because if a cirrhosis is decompensated, you want to make sure they do not have spontaneous bacterial peritonitis. And if you have greater than 250 PMNs, okay, you're going to be concerned about SBP. So any cirrhotic presenting with ascites, you're going to have to do this to rule this out. The most common bacteria causing this is E. coli. And then you will also send the micro. You really can't do it. Gram stain's not very helpful, but you are going to send micro. Now, if somebody has a low SAG and you suspect malignancy, and the tumors you think of, number one, ovarian cancer, and also some of the intra-abdominal malignancies like cancer of the pancreas or stomach cancer. And clearly, if a patient has one of those underlying malignancies and they present with ascites, you're going to think of that, and you're going to send the fluid for cytology. If you suspect tuberculosis, you're sending the fluid for AFB. If it's acute pancreatitis, there's going to be other stuff going on. Meigs syndrome is something that it's associated with benign ovarian masses where they have ascites and hydrothorax. That's not a real common cause here, but it's on the differential. But these are the things that you are going to send. You're going to generate, a differential. Another bugaboo here with CHF, their sag will be high, but they're able to put a protein in the fluid. So with cirrhosis, you're going to have low acidic fluid protein, but it will not be low. It could be elevated in CHF because the pores are still open, okay? Unlike cirrhosis where you have proliferation of the stellate cells, and protein, although not albumin, but protein could seep into the perineal fluid. So that's another pearl. If somebody presents with heart failure and they have ascites, then you're going to send acidic fluid for protein. The other bugaboo, if somebody develops acute ascites, wham, like that, you have to think of hepatic vein thrombosis and then figure out the reasons for that. The most common cause would be a myeloproliferative neoplasm. And then if it were a woman, you'd want to know if she were on an estrogen-containing product. Just a couple words about treating ascites in the cirrhotic. These patients, okay, the mainstay of treatment of diuretics and large volume paracentesis, initially they will be admitted. If you put them to bed rest and you elevate the legs, you're going to increase venous return. And, that could decrease some of the counter-regulatory forces. So bed rest and a low sodium diet. And then you're going to diurese. Now, the key diuretic here is spironolactone, and you're going to use it with a loop diuretic, but you cannot use a loop diuretic alone. Okay, you need to have the potassium-sparing diuretic on board. And here's the bugaboo. These patients have secondary hyperaldosterone. Aldosterone is really revved up because of the decreased effect of arterial blood volume. And if you give them a loop diuretic, like furosemide, you're going to get increased sodium presenting to the collecting duct. Aldo's there's a lot of aldo. It's going to resorb the sodium and it's going to dump potassium into the urine. They're going to get profoundly hypokalemic, and you could also precipitate hepatic encephalopathy. So if you're diuresing these people, you need a case-sparing diuretic, and then usually you add furosemide. If that doesn't do the job, you may need to do a large volume paracentesis. But if you're doing that and you're taking off more than 5 liters, which is usually done, you have to, to maintain hemodynamic stability, give IV albumin with that. And then after that, if that doesn't work for cirrhosis, then you might have to do TIPS, transjugular intraportal peritoneal shunting. That's how you treat cirrhosis in the cirrhotic. If it's due to CHF, you're going to diurese the patients, and hopefully they will respond. Malignancy, you can treat with chemo, tuberculosis, anti-TB meds. So in summarizing, you treat peritoneal fluid different than pleural fluid. You have sag, not transidate and exudate. You figure out the cause. If it's a high sag and you think it's due to cirrhosis, you need to rule out spontaneous bacterial peritonitis, and then you need to treat with potassium sparing and then loop sparing diuretics. And I'm going to stop for now.